So what I'd like to do today is give you a little bit of a status report of where we are in the prevention of HPV-associated cancers. And I'll be telling you a little bit about the really substantial successes that we've had in preventing HPV-associated cancers, but I'll also tell you about some of the problems that remain and things that still need to be done. So starting with a little bit about the burden of HPV-associated cancers. If you look at it worldwide, it's really dominated by cervical cancer, both in terms of the total number of cancers, about 500,000 each year. In the attributable fraction, almost all cervical cancers have as their basic cause HPV infection. Now, if you look at the United States, it's a little bit different, both in terms of how much cervical cancer is the major cause of HPV-associated cancer and the burden of women in comparison to men. And the reason this is basically twofold. One, we have Pap screening, which has been very effective actually at preventing cervical cancer. It's been estimated to prevent about 80% of cervical cancers. And the other thing is there's been what's been described as an epidemic of HPV-associated oropharyngeal cancers. In men, about 60% of those cancers occur in men and not women. So it really provides an opportunity to prevent HPV-associated cancers in men as well as women. So the vaccines that we'll be talking about today are composed of what we call virus-like particles. And what these are is basically the outer shell of the virus without any of the guts. None of the nucleic acid, the DNA is in them, just made from one proteins. And this was sort of the key technological advance that led to the development of these vaccines. It's actually something that we did in the intramural program at the NCI. And there are two commercial vaccines. One is called Cervical, which is manufactured by GlaxoSmithKline, that targets HPV 16 and 18, which accounts for about 70% of cervical cancer in the United States and also worldwide. And Gardasil, which is the main vaccine used in the United States, is manufactured by Merck. And it, in addition to the two cancer-causing types, contains HPV 6 and 11, which cause about 90% of genital warts. So these don't cause cancer, but do cause a significant problem in people. And I should note that both vaccines are administered in 3 doses over 6 months in the United States. And just recently, Merck has come out with a new vaccine called Gardasil 9. Now, Gardasil 9, in addition to the 4 types that are in the original Gardasil, contains VLPs against 5 more oncogenic types. And so we could potentially protect against about 90% of the types that cause cervical cancer, and at least 90% of the types that cause the other cancers, which are actually more predominant with 16 and 18. So just to give you a brief overview of what we know about these vaccines in clinical trials and then in general use, is that contrary to what you might read on some websites, these vaccines are very safe. There's no suggestion that there's any pattern of serious adverse events that have been associated with these. They do induce a little bit of low-grade pain, just like any other injection, but other than that, they basically are very well tolerated. And they're remarkably effective. This is the first vaccine against the sexually transmitted disease. And I can tell you, when we first talked to companies about this, they said that sexually transmitted disease vaccines are not going to work. It was very hard to convince companies to actually take up the gauntlet and develop this vaccine. But in reality, it protects against virtually 100% of precancers that are caused by HPV 16 and 18 infections. We can't use cancer as an endpoint because we can't let women in a trial with active follow-up progress to cancer. We have to treat them before that. And in addition, as a bonus, Gardasil protects against genital warts by about 95%. Now, there's limited protection against the other types in the vaccine, which was one of the reasons why Merck added these new types. And unfortunately, they're not effective at pre-existing infections. This vaccine is totally preventative. It prevents HPV infection. If you have the infection or an HPV-associated precancer or cancer, it'll do nothing to make that go away. So that's why it's very important that women and also men get vaccinated before they're exposed to the virus. So I'd just like to point out that in some ways the development of the HPV vaccine is sort of a poster child for the private sector and the public sector coming together and doing what they do best. So there was no way that industry would have determined the basic knowledge that HPV is the central cause of cervical and several other cancers. It's just something that companies don't do. They also would not have developed the HPV technology, the VLP vaccine technology, because it was too risky of type of enterprise. And that's why this is something that was done in an academic, or in this case, a government setting. And then we also went on and did vaccine validation in preclinical models. And it was at this point, when we had that data, we were able to convince companies to spend their hundreds of millions of dollars to do the next critical steps, which involved industrial scale vaccine production, and then doing the large scale clinical trials involving tens of thousands of women to show that these vaccines could actually work at preventing pre-cancer and obtain FDA approval, and then spend additional hundreds of millions of dollars in marketing and distribution. And the outcome of this essential partnership really has led to an intervention that has major potential for preventing cancers, and in addition has provided jobs and opportunities for American pharmaceutical industry. So this is one case where the government's dollars has primed the pump to generate not only a public health intervention, but also to increase US manufacturing. Now, what I told you so far is the bright side. So now we're going to get a little bit into the clouds. And the first cloudiness here is that uptake in the United States lags substantially behind other countries, although we do better than France, if that's any consolation. So only about half of the women, or the young girls, this is in girls, receive the vaccine in terms of one dose, and they're supposed to get 3 doses, and only about a third of girls in the United States are getting the prescribed number of 3 doses. And one of the issues is most countries who do well in vaccination have school-based programs where the girls and now boys just line up and get vaccinated when they're 11 or 12. And it's very easy, it's not difficult for people to do. Whereas in the United States, and interestingly also in France, it's clinic-based. So it's difficult for parents to take off 3 times in 6 months to take their kids in to be vaccinated. The default is easier just to not do it. And it's unfortunate that HPV vaccine is kind of special because it actually lags behind the uptake of other adolescent vaccines that are targeted to the same age group, as you can show here. This is diphtheria, tetanus, acellular pertussis, and this is meningococcal vaccine. And even if you compare one dose, it's lagging behind and starting to plateau. In boys, it's still increasing because there wasn't a license for boys until 2009. So this just really says that when the kids are going in to the clinics to get one vaccine, they're not necessarily getting another. And CDC has recommended that if each opportunity for vaccinating an adolescent was actually taken, we'd have vaccination rates of over 95%. So what's going on? Well, let me just say that there's also, unfortunately, unequal distribution of uptake of the vaccines via states. And the worst part of this is that the states, it's a little bit hard for you to see here, but the states that actually have the highest rates of cervical cancer, which are shown by these stars here, are pretty much the same states that have low uptake rates. And so if all we're vaccinating is girls that are going to end up receiving Pap screening when they get older, we're not actually going to do that much to reduce cervical cancer rates. We have to get these vaccines to the kids who aren't going to get adequately screened. So that's really the big issue here in the United States. Now, it's really sad that this vaccine isn't being utilized up to its fullest because it is working at preventing HPV infections. And this is very recent data that was published by the CDC that shows in the youngest group who are getting vaccinated the most and most likely to be vaccinated before they get exposed to the virus, the incidence of infection by the types that are targeted by the vaccine has gone down by almost 2/3. So this is really remarkable in the 10 years since the vaccine was first introduced. We're not doing as well in older women because it's more likely that they would have already had an infection prior to the time they got vaccinated. So this is showing that the vaccine really does work. So what are we going to do to increase vaccine uptake? Well, probably the most important thing is to convince general practitioners and pediatricians to more strongly recommend the vaccine. There's something that's going on in the doctor's office where they're getting those 2 other vaccines and they're not getting the HPV vaccine. And it's being made a special case where they're saying in some cases you need to take this, and for the HPV vaccine they're saying you can take this. And so we need to educate and probably monitor their vaccination rates to see who's doing a good job and who isn't. The second point is overcoming parental hesitancy. And I think the key to this is to, one, stress cancer prevention, not the fact that it's a sexually transmitted disease, and to tell parents that the reason they need to be vaccinated when they're 9 to 14 rather than later is that the vaccine actually works better in a pre-adolescent than an adolescent boy or girl. The antibody response is actually better. In European countries, for instance, if you're under 14, you only need 2 doses rather than 1 dose. So this is really the story that we have to tell parents is get it now because it works better. Another issue is countering misinformation campaigns by anti-vaccine groups, which clearly has been an issue. And also, it'll be important to promote vaccination in non-clinic settings, for instance, to allow pharmacies to deliver this vaccine. I mean, I have a young daughter, and I know that she spends a lot more time in the local CVS than she spends in the local clinic. Okay? So if CVS could administer the vaccine, I think we'd have much better uptake, or at least somewhat better uptake. And lastly, it's important to support 2 doses for less than 15. WHO recommends 2 doses for less than 15, and most European countries have this. And this is something that's going to be taken up by the US FDA and the CDC in the future. And hopefully we'll get to a 2-dose for under 15, which not only will save money, but hopefully increase uptake at a younger age. So in terms of screening, we're really moving away from the pap smear, which looks at abnormalities in cells scraped from the cervix, towards an HPV-based screening strategy. It kind of makes sense. If we know that without HPV you don't have cervical cancer, that looking at this primary cause would be a good way to screen. And the idea would be that we would combine it with vaccination. So this initial peak of HPV infection at early ages would be diminished, especially by the 9-valent vaccine. And then rather than screen very often with a pap test, which has what's called not such good negative predictive value. In other words, if you get a negative pap smear result, you still have a reasonable chance of getting cervical cancer because you can miss the lesions. But if you screen often enough, you're going to get it before it progresses to cancer. Now, HPV has a much better negative predictive value. If you're negative for HPV DNA at a test, the chances of you getting cervical cancer in the next 5 years is pretty much 0, almost probably in the next 10 years. And so we'll be able to screen less often in low resource settings, maybe 1, 2, or 3 times in a lifetime, and still get good cancer prevention. So one of the issues now is that we're kind of in this transition period of cervical cancer screening, and there's a bunch of options out there, and it can get confusing. For instance, women can start at 21 with pap screening and get screened every 3 years, or there can be what's called co-testing, where you get an HPV test and pap testing. Now you can go to every 5 years, but it doesn't start until you're 30. Or even recently, you can just do HPV primarily, and they've been very conservative and say it has to be at least every 3 years in women who are 25 or older. So the issues are that we need to educate women about their options and not have them freeze because of the multiple options that are available to them. And then convince vaccinated women to continue screening. The vaccine will only work if you haven't been exposed prior, if you get vaccinated prior to exposure, and it doesn't protect against every single type. And then we need to clearly discourage overscreening, because some women are still getting, for instance, pap screen every year. That's clearly not recommended and can lead to substantial overtreatment. So what's next? This is my last slide. Well, one of the things that we at the NCI are extremely interested in is to see if this could be the first 1-dose vaccine that's a subunit vaccine. And the NCI conducted a clinical trial down in Costa Rica, and a certain number of women only got 1 dose. And remarkably, we found that Now, they weren't randomized to have one dose, but some of them just happened to it. But none of the women who got one dose got HPV infection. And so statistically, it worked just as well as one dose as in 2 or 3 doses. And we're now going to embark upon a randomized clinical trials where we're going to compare formally number of doses and see whether we can make this a one-dose vaccine, which would be transformative in terms of implementation, especially in low-resource settings. We need to better establish what the optimal cervical screening strategy is for vaccinated versus unvaccinated women, because clearly vaccinated women, especially with the 9-valent vaccine, will probably get by with far fewer screenings. And this would save a whole lot of money and also prevent over-treatment. Another issue is how to manage women who are diagnosed with HPV infection. Already we're getting some pushback because if you're diagnosed with an HPV infection, okay, you have an infection that's potentially oncogenic and a sexually transmitted disease that's transmissible, and you ask the doctor, what can I do about it? He'd say, he or she has to say, well, basically nothing. We have to see if it goes away by itself. And if it doesn't go away and it progresses, then we'll have to cut it out. And so we really need safe and affordable interventions at an early stage where we're first diagnosing the lesions. We have nothing right now. This is, again, something else that we in the NCI are working on. And finally, can we develop effective screening treatment programs for other HPV-associated malignant lesions at other sites, for instance, oral or anal? And this is something that hopefully Eric will talk a little bit about in the next talk. So final thoughts. Government-sponsored research and investment by the pharmaceutical industry has generated interventions that could essentially prevent cervical and other HPV-associated cancers in the next generation of men and women. But it's important to note that these interventions need to be better utilized for their full potential to be used. And it's very frustrating as someone who was involved in the initial development of the HPV vaccine to see something such a safe and effective intervention be so grossly underutilized. And lastly, there still is an unmet need to better diagnose and treat individuals who already have oncogenic HPV infections, whether they're at the cervix or anal or oral sites. So thank you very much for your attention.